Welcome everyone to a webinar rather, of the Maricopa County Medical Society. And our guest speaker today is Dr. Alissa Darden. She'll be introduced by Dr. Karine Benalis, who is a member of the Board of Directors of the Maricopa County Medical Society. For more information about MCMS, go to mcmsonline.com. This presentation is under the auspices of the Diversity Subcommittee of MCMS, also led by Dr. Benalis, and has a lot of members of the medical community in Maricopa County involved with trying to find ways to improve the diversity, equity, and inclusion of the physician workforce. So if you're more interested in participating in those efforts, please contact us at mcmsonline.com, reach out to staff, or call us. This webinar is eligible for up to one AMA PRA Category 1 credit in a joint sponsorship relationship with the Moore Foundation under the auspices of the Arizona Medical Association. It is my honor to introduce Dr. Karine Benalis, an endocrinologist at the Phoenix VA Medical Center, who will then introduce Dr. Darden. Dr. Benalis.
Hi, everyone. Thanks for joining us this night. It's my pleasure to introduce Dr. Alissa Darden. Dr. Darden graduated from medical school from the Johns Hopkins University School of Medicine, and did her residency in pediatrics at the University of Pittsburgh Medical Center and the Children's Hospital of Pittsburgh. And since then, she has been with Phoenix Children's Hospital, where she is leading not only Phoenix Children's, but also the University of Arizona College of Medicine Phoenix towards more diversity, equity, and inclusion. And it's my privilege to introduce her tonight to talk to us about implicit bias. Dr. Darden, the floor is yours. Thank you so much for being here with us tonight.
Absolutely, it's my pleasure. I am going to try to share my screen. All right, can you guys see that slide?
Yes, ma'am.
Awesome, perfect. So thank you so much for that introduction. I greatly appreciate it. Today, we're going to talk a little bit about implicit bias. This talk is really entitled, What You Don't Know Can Hurt You and Your Patients. And it's implicit bias and its impact on healthcare disparities. I want to do the obligatory disclosure statement first. I don't have any financial relationships to disclose, unfortunately, and I do not plan to discuss any unapproved or off-label uses of products. The objectives of this talk are as follows. I want you to be able to understand and define implicit bias and describe the science behind it. You should be able to define microaggressions and identify them in both clinical scenarios and everyday life. Also, you should be able to recognize the impact of bias and microaggressions on healthcare disparities and detail strategies to mitigate that bias. Before we look at implicit bias and its impact on patient care, I want to take a step back and explore the science behind bias. Our brains are amazing. They complete complex computations faster than any smartphone on the market. In fact, our brain processes about 11 million pieces of data unconsciously, but only about 40 pieces of information on a conscious level. Thus, our brain has created shortcuts called schemas to help us successfully navigate the world around us. When given a choice, our brain will often choose the simplest and fastest path, which often includes previous association. It's really one of the aspects of the human brain that makes it most unique. However, sometimes our brain makes mistakes in processing, just like we do when we're rushing and moving too fast. However, these mistakes are mostly happening on an unconscious level, and they lead us into the pitfall of bias. These mistakes were playfully coined mind bugs by two Harvard psychologists by the names of Banerjee and Greenwald, who have done a tremendous amount of work in the field of implicit bias. They define Mindbugs as ingrained habits of thought that lead to errors in how we perceive, remember, reason, and make decisions. But before we look at Mindbugs, I'd like to explore this idea of schemas or shortcuts a little bit more thoroughly. Schemas really are cognitive frameworks that help us interpret and understand the world around us. It's how we're able to quickly assess our environments, particularly for things like safety. However, these mental frameworks also cause us to exclude information that may be pertinent so that we can focus really only on things that confirm our pre-existing beliefs and ideas about something. Schemas can contribute to stereotypes and make it difficult to retain any new information that doesn't already conform to our established ideas about the world. Here are a few examples of schemas. If we take a look at the person schema, for example, most of us probably have a best friend, right? We know what our best friend looks like. We know what our best friend's personality is like, what things they might like and not like, and how they behave in certain situations. So when we take our best friend to, say, a new movie, we generally have an idea of how that person's gonna like the movie. Or if we put them in a new environment, we generally know how they're gonna act because we know their person schema. We even have self-schemas. Thanks to our environments, our upbringing, the media, the world around us, we all have schemas that include ourselves. This is a schema that maybe some of us had growing up in particular. We knew we wanted to be doctors when we got older. We were likely pretty smart. Maybe some of us considered ourselves funny, and maybe we weren't too keen on vegetables. Sorry, let me go back one second. There we go. Social schemas. We'll talk a little bit more about social schemas in another few slides. But social schemas kind of help us figure out how to navigate social situations. So for example, when we go on a date, we know that we're supposed to be respectful to the other party. We may even have ideas about who's supposed to pay for that date. We try not to eat stinky foods like garlic because we want to respect the person who's there with us and not gross them out, right? Finally, we have event schemas. We know that when we go for a job interview, we're supposed to wear a certain type of outfit, like a business suit. We know that when we meet them, we're supposed to give them a firm handshake. At least pre-COVID times, that's what we would do. We bring all of the necessary material for that interview, and we arm ourselves with professionalism. For the most part, these are things that we don't really have to think about consciously. We don't have to remind ourselves to be professional on an interview. We don't have to constantly say to ourselves every day that we're smart. We know that we are capable, or at least we should. And these things really live on an unconscious level, but they help us navigate the world around us. These are just a few examples of schemas. There are a lot more that we could discuss. I do want to play around with the person schema just a little bit for fun. It helps just to help us better illustrate how these things work. This is someone that I am going to assume all of us are familiar with, the 44th president of the United States, Barack Obama. I'm going to use him as an example for a person schema. The things in pink are different titles or characteristics that we might ascribe to Barack Obama. We know that he is #male. He is #Black, and he is #middle-aged. If we break down the Black category just a little bit and look at some of the characteristics and maybe even stereotypes that are often ascribed to Black people, we get maybe some of these. That he should be athletic. We think that Black males in general are athletic. Well, for this president, we know that that holds true. He played a lot of basketball during his presidency and looked pretty good at it. So I'm going to guess he's pretty athletic. We might say that in general, Black people don't know how to swim. Well, I'm judging by this picture that he's actually probably a pretty good swimmer. And finally, we might say that he's uneducated because that's a stereotype that's sometimes ascribed to Black people. Well, we know that this president in particular was very well educated. So if we were to encounter someone like him, or maybe a less famous version of him, and we made these assumptions, we'd be pretty wrong about who he is as a person. This is just an example of how sometimes these person schemas can lead us down the wrong path. And that's what Mindbugs really are. It kind of leads us to come up with conclusions that aren't accurate. So let's take a closer look at Mindbugs. Remember, Mindbugs are ingrained habits of thought that lead to errors in how we perceive, remember, reason, and make decisions. They are our blind spots. This is a famous optical illusion. It's known as Shepard tables, after a Stanford psychologist by the name of Roger Shepard. When we ask people which of these tables is longer, most of us will say the table on the left looks as though it is longer, when in reality, the two tables are equal in length. The interesting thing is that your retina actually sees this correctly, but your brain tries to convert this 2D image into a 3D image, and that's where some of the trouble begins. So I want to reiterate, your eyes are not fooled. Your eyes see this correctly, but when it translates that information to your brain, that's when we come up with incorrect conclusions, like the table on the left is longer than the table on the right. This is really kind of the purpose of optical illusions, right? Our brain is fooled, even though our eyes technically aren't. But much of this work is happening on an unconscious level, and it's a perfect example of how Mindbugs or blind spots work. Let's look at an example of a social mindbug to help you maybe better conceptualize this. Social mindbugs are habits of thought about social groups. The media is one of the biggest influencers here because they often create and maintain these social mindbugs. But we often don't catch them or even see them as problematic because they may confirm what we already believe on an unconscious level. Let's look at how two different groups of people were portrayed in a Yahoo News story in 2005 around the time of Hurricane Katrina. Both groups are in the exact same situation, but the white people in the picture on the left are portrayed in a more positive light, even though they're doing the exact same thing as the Black people in the picture on the right. The mind bug here is that white people find, but Black people loot. The writer transferred his own bias into this story, and it wasn't even caught by the editorial team because it was likely an unconscious bias that they held as well. But just because it's unconscious doesn't mean that it doesn't have great impact. Let's look more closely at the difference between social schemas and mind bugs. Social schemas are basically the way we interact with people around us. We tend to sort people into categories, and we don't really see them technically as individuals. We assign traits to people based on to what categories they belong. Those traits can be good or bad, and they create kind of an emotional valence or reaction within us. We began to develop attitudes, which are kind of your general gut feeling, and sometimes even stereotypes. So we associate a specific trait with a group that then can cause us to have some bias. With bias really just being a divergence from a neutral point. You can either be biased for it or biased against it. Now, we have two different types of bias. There's explicit bias, where we know that these are attitudes and biases that we know about ourselves. If you asked us, if you asked yourself, do I have a bias against women? You might be able to answer that honestly. However, implicit bias actually refers to attitudes and beliefs that affect our understanding, actions, and decisions in a more unconscious way. Makes it difficult to control. This is where a lot of the mind bugs or blind spots reside. However, the fact that it's difficult to control does not make it impossible to control. And we'll talk about strategies and how we will help to mitigate bias a little bit later in the talk. But where do we get this information for us to be able to get these general gut feelings or attitudes or form these stereotypes? We tend to get this information in two ways, either directly, meaning we have gained knowledge about a particular social group or category through a personal interaction, or indirectly, which is more common, we gather information from pop culture, from the media, from social media, from the experience of others like our own family members. And based on that info, we develop attitudes and stereotypes about the group. So while social schemas can be good or bad, right or wrong, they kind of help us navigate the social atmosphere. Social mind bugs, on the other hand, are always wrong. They are the stereotypes. They lead us to trust some people, but not others, simply because of the social group that they belong to, or at least the one we think they belong to. Social mind bugs guide our decision-making based on group membership, race, ethnicity, gender, class, etc. Now, some of these characteristics are more magnetic than others. Get this, even thanks to the media, our environment, the way we've kind of grown up, we even have social mind bugs about ourselves. These can negatively affect our actions and feelings toward ourselves and decrease our own self-confidence. Further, social mind bugs can help explain why we have things like racism, sexism, homophobia, transphobia, and other forms of discrimination. And they provide some insight into what creates and maintains systemic discrimination. The bottom line is that these mind bugs are harmful to all of us. Let's look at a few more examples of how these mind bugs, which are representatives of our own unconscious bias, can lead to tremendous real-world impact. One of the most popular examples used as a real-world consequence of bias is the Boston Symphony Orchestra auditions. In the 1950s, they began instituting blind auditions, which really were the first of their kind. So what they decided to do was they put up a curtain so you couldn't see the person who was auditioning, and they put down a soundproof floor so you also wouldn't be able to discriminate based on the way high heels sound, knowing that it was a woman there. What they found is that they increased the number of women who made it past the preliminary round and eventually into the orchestra by more than 50%. In addition, they began to advertise for the auditions in places that were atypical. So instead of the normal word of mouth or advertising in communities where they typically got their members, they decided to advertise in communities that were different, and in newspapers that maybe they didn't traditionally read. When they brought in their search, they found that they increased the diversity of the orchestra as well. Another example of real-world consequences of our bias is in policing.
It was a high-pressure situation. An officer made a judgment call. There's no judgment in that call. It was just a reaction. You see skin color. We all do, but the reaction that you give to a white kid versus a brown kid in that split second, that's the measurable, fixable difference. Bias is human. You have guns. You're using guns, so yours is lethal. We aren't racist. I didn't say anything about racist. I said bias. And lucky for us, bias is fixable. You have protocols in place. Those can be adjusted. You can fix it. Or you can keep pretending that it doesn't exist at all. Kids are dying. This kid is dead. For what? So many people that look just like him are dying. For what? Doctor, I'm sorry, we still need a statement.
My statement is that a little boy was at home when your fellow officer shot and killed him. You can't just be out there shooting people because you're afraid. How am I supposed to have any faith in a system like that?
I show these examples to illustrate that implicit bias really is everywhere. Here are some more examples. When YouTube first had the upload feature in their app, they found that 5 to 10% of users were reporting that their videos were upside down, which was puzzling to the company. It turned out that they had basically created an app that was exclusively designed for right-handed people. Left-handed users, who typically hold their phones rotated about 180 degrees to shoot videos, weren't able to use the app. It wasn't until they fixed this that all users were able to use this app successfully. Turns out they had no left-handed people on the creative team for the app. It's in the callback rates for interviews. We know that studies show that if a resume has a European sounding name, it will get a higher callback rate for an interview than the identical resume with an ethnic name. We see it in the evaluation process for jobs, for example. Women who are confident or ambitious often get negative evaluations, while their male counterparts will be praised for the same characteristics. It's in how we interpret body language. It's in the likelihood of shooting an unarmed Black man. They did a study where they had police officers play a video game. And they found that the police officers often were shooting the Black suspect, and they swore that the suspect had a gun, when in fact, they did not. And they were more likely to shoot the Black suspect than the white suspect in that video game. And finally, it's in our hiring practice. We see that without diverse teams in place, the hiring of gender, ethnic, and racial minorities is significantly decreased. But surely we don't have bias in medicine, right? The truth is we have a bias problem in medicine too. We're not immune to bias just because we're good people and we took an oath that we would do no harm. Good people have bias. We all have bias. It's everywhere in medicine. It's in pain management plans. It's in birth outcomes, treatment decisions, diagnostic algorithms. So where do we go from here? Do we just resign ourselves to this fate, or do we try to fix it? Well, the answer is, of course, we try to fix it. But first, we have to admit that we have it, and that's maybe the hardest step. To help us with this, let's look at some data. We all love evidence-based medicine, right? Well, let's look at the evidence on implicit bias, how it's measured, and whether or not it can predict discriminatory behavior. Because if our bias, in fact, leads to discriminatory behavior, then we know it's something we have to fix, right? This meta-analysis used the implicit association test, which is the brainchild of Anthony Greenwald and Mazarin Banaji, who I mentioned earlier. What they found is that that test was a better predictor of discriminatory behaviors than any explicit measures, with an R value of 0.236. Now, before you tell me that R value is not that impressive, I want to compare it to the R value of cigarettes causing lung cancer, which is a pretty low R value. However, we often counsel our patients that they shouldn't smoke, right? So if we believe that R value, then we must believe this one as well. Let's look at the nuts and bolts of how an IAT works. Actually, sorry, let me go back one slide. Before we do that, let's look a little bit first at the history behind the IAT, and then we'll work our way towards how the IAT actually works. The first IAT was developed in 1994, but it was first published in 98. There were 3 Harvard psychologists who worked on this. It's considered one of the most popular measures of implicit bias and considered to be the most influential psychological development of the last several decades. It's been cited thousands and thousands of times in the literature. So how does it work? It measures your reaction time in a sorting task. It asks you to sort pictures and words. The quicker your reaction time, the stronger association. So, for example, if we know something to be true, it should be easy for us to answer a question, right? However, if we're a little unsure about it, it may take us a little longer to answer that question. So, if your brain has formed a very strong association between a social group and a word or characteristic, you should be able to respond to that quickly. Like, if you think white is good, Black is bad, you should be able to answer that pretty quickly. However, if your brain thinks that those two things are actually on the opposite ends of the spectrum, it's going to take you a little bit longer to react. So your reaction time is going to be slower. There are a ton of IATs out there, race, gender, age, etc. If you want to give one a try, you can simply Google Project Implicit, or you can use this website here to take a test and measure your own degree of bias. Now let's look at the nuts and bolts of how this test works. I'm going to use the race IAT as an example here. Again, the basis of the IAT is that our brain finds it easier to sort concepts that are more closely linked. The IAT measures how quickly we associate words with pictures. For this IAT, we're going to use black and white pictures and good or bad words. There are 4 trials when you do the IAT. In the first trial, they ask you simply to sort the faces. So they'll say, push a key on the left for white faces, push a key on the right for black faces, and they'll have you go through a number of pictures. In the second trial, they'll change that to words. They'll put good words on the left and bad words on the right. During the third trial, they put either a picture or a word. So they'll either put a white picture or a good word on the left-hand side, or a black picture or a bad word on the right-hand side. This in that trial, it would be easier to do that if you have a white preference. Like, you're going to be quick at picking the white pictures, good words, versus black pictures and bad words, if you have a white preference. During the fourth trial is where things get a little bit more complicated. They will put white pictures and bad words on the left and black pictures and good words on the right. It is a much harder task if you have a white preference to do that. You'll have more errors, your reaction time will be slower. That's called the IAT effect. This is where they really figure out if you truly have a bias, because again, your reaction time is longer than it was in the earlier trials. If you don't have a bias, your reaction time really should be the same. So millions of people have taken these IATs on the Project Implicit website. And what we see is that bias is systemic, pervasive, as evidenced by the people who've taken it thus far. No one is immune to bias. We can even be biased against our own group. I'll be honest, the first time I took one of the IATs, I was shocked because it showed that I had a slight white preference. And truly, I felt like this test is flawed. This can't be right. I, as a Black woman, do not have a slight white preference. So I tried to take it multiple times to see, can I fool this test? Are these results really reproducible? And they were. When I reflected on that, it made me remember that I grew up in the exact same culture as everyone else. I'm still susceptible to the stereotypes that are portrayed in the media, even when they're stereotypes against people who look like me. When you go through the data from millions of people taking these tests, you see some of the preferences that we have around the world. We prefer young people to old people, so we have a little ageism there. We prefer thin people to fat, and we all know in this country that we have fat phobia. We prefer white people to Black, and those who are able-bodied to those who are disabled. 72% associated Black people with having a weapon, which I guess explains why we've had such difficulty over the last couple years with the shooting of unarmed Black folks. 61% felt that Asians were foreigners, even though many of the Asians were born here in this country, at least the ones that are being referenced in the IAT. And 76% associated women more with families than with careers, even though women have been in the workforce for quite a while, and in some careers actually outnumber the men. Now that we've taken a look a little bit at bias, the science behind it, how we measure it, I want to talk a little bit about how bias is often expressed. And that's through microaggressions and macroaggressions. I call them the language of bias. Macroaggressions are obvious. It's overt racism. It's the I don't want a foreign doctor, girls aren't good at science, Black people are lazy. We can identify overt racism and macroaggressions pretty easily. It's the microaggressions that are a little bit more subtle, that are difficult for us to pinpoint, and sometimes leave us thinking, was that offensive or not? It's the things that make you feel othered. It's the female physician who walks in a room and the family immediately says, the nurse just came in. It's asking, an Asian physician, do you speak English, or complimenting their English when English is their first language. Or asking if there are any doctors from America here when someone who is an ethnic minority walks into a patient's room. So what's the actual definition of a microaggression? This term was first coined by Chester Pierce, who was a psychiatrist at Harvard University in the 1970s. I find it interesting that this term has been around for so long, and it really is just getting popular over the last couple years. Microaggressions are a brief and commonplace daily, verbal, behavioral, environmental indignity, whether intentional or unintentional, that communicates hostile, derogatory, or negative slights and insults towards a people of a marginalized group. And the marginalized group is an important part of that definition. There are 3 types of microaggressions. The first is micro insult. That's a comment or an action that is unintentionally discriminatory. For example, calling a Latina resident spicy. There's the micro assault, which is when a person intentionally behaves in a discriminatory way while not intending to be offensive. So when a male attending makes a sexist joke during a lecture and then just says, "I was just joking." And the last one is a micro invalidation. It's when a person's comment invalidates or undermines the experience of a certain group of people or makes them feel othered. It's asking someone, "Where are you from?" And when they say somewhere in the United States, saying, "No, but where are you really from?" Or "Where are your parents from?" It's the telling Black people that you don't see color or that racism doesn't exist. While these all seem small sometimes, like not a big deal, it was just a joke. But really, it's the cumulative impact of these microaggressions that is harmful. The body interprets this as trauma, and they say that the cumulative impact is likely equal to one major catastrophic trauma. There are significant emotional effects. There's the mental health of the recipient who's affected, their emotional well-being. There's cognitive effects. The increased cognitive load to interpret these microaggressions, make sense of them, what they mean, disrupts your cognitive processing. That means that you're going to have decreased focus on the things you should be doing, which may decrease your productivity. How this might play out is, say you have an underrepresented minority resident on your team or a physician in your practice. Their productivity may be less, their performance may not be great when they've had to deal with microaggressions on a daily basis. Even though they're capable of doing the work, the fact that their cognitive load has been increased by having to deal with these microaggressions really impacts their performance. Also, there's the stereotype threat, where people become kind of a self-fulfilling prophecy, meaning if you've been basically told that you won't amount to anything, or, you know, Black people don't make great doctors, then you may start to live up to that and underperform. And finally, there are behavioral effects. There's the hypervigilance or skepticism of people of a majority group. There's the rage or anger that people might feel. There's fatigue and hopelessness. And honestly, during this pandemic, if you asked most Black people how they felt after the George Floyd incident or after Ahmaud Arbery, you know, there was a lot of fatigue of having to deal with these things over and over and constantly process this trauma. Again, all of these things cumulatively is what has such a huge impact. So we want to make sure that we're able to identify microaggressions so we stop committing them and causing that stress and that trauma to others. There are a variety of ways in which microaggressions, which again are the language of bias or how our bias is often expressed, and how they impact our healthcare system. As we saw in the IAT result, we have an anti-fat bias in this country. Many patients who are overweight or obese will report avoiding going to doctor's visits due to fear of bias or shaming. When they did a study looking at the bias of medical students, they found that 2 out of 5 medical students had an unconscious bias against obese people. This greatly impacts the doctor-patient relationship. It means that you miss the opportunity to counsel people, to pick up on diseases early so that you can intervene in a timely manner. Microaggressions also impact patient-provider communication. Clinicians order fewer tests for racial and ethnic minorities when they don't understand the description of the symptoms. This is why many have suggested that having the patient and patient-provider racial and ethnic concordance may improve this, because if I understand your cultural norms or the way you typically describe things, then I might be able to better treat whatever problem you have. And ultimately, that improvement in communication may lead to a decrease in some of the health disparities that we see. In terms of sexual orientation, if the provider is uncomfortable about asking about your sexual orientation or misgenders you during the visit, you're going to be less likely to trust that physician. There's also going to be a missed opportunity for tests and screenings that those populations may need. We know that studies show that lesbians are less likely to be offered screening mammography. Transgender women are more likely to have advanced HIV due to lack of screening. Sexual minorities have higher rates of mental illness and sexual assault. You can't screen for these things if you're unwilling to have the conversation or to learn about these populations so that you aren't committing microaggressions against them. And finally, it's in our hiring practices. We know that we have a lack of physician diversity. And the data on diversity in the workforce shows that diverse teams are more innovative, creative, and able to solve problems more effectively. Also, there's some data that there are improved outcomes when you have diverse teams. One good example would be the study showing that Black babies had decreased mortality when cared for by Black doctors. There are also studies that show that there are less surgical complications and better outcomes when your surgeon is a female. None of this is to say that if you aren't a member of a racial or ethnic minority, that you can't take great care of patients, because you can. So now that we've established that we are all biased, and sorry, one second. Yeah, that we're all biased. Let's talk about what we do to fix it. How do we mitigate bias? So first, I want to point out that it is impossible to remove all bias. Our only hope is to mitigate it using a variety of strategies. And here are some of the strategies, and we'll go through them one by one. The first step is to get out of denial and, again, admit that we all have bias. We must recognize it and accept this before we can attempt to mitigate it. Bringing our mental associations to the surface will help us disconnect those associations. We have to remain humble, because even those of us who've been doing this work for a long time make missteps and commit microaggressions. We have to remember that things like fatigue, distractions, stress, time constraints, multitasking, high emotions, all these things increase the chance that our bias will be activated. We have to be motivated to do more and to be better. So the first strategy that we will talk about is counter stereotyping and stereotype replacement. These are two different versions of the overall same concept. First, actually, before I begin, I want to mention that these strategies that we're going to talk about have all been looked at in the literature and found to be successful. There are likely other strategies out there that may also work. These are the ones that either I have used personally, or I've read the data about and feel that they are things that we can all adapt and add into our everyday life. They're simple, they're easy, and I think that they can be successful. So the first is counter stereotyping. So this is when you create the opposite image of a stereotype in your mind and form a positive association. This picture here is an example. We don't traditionally think that women are good in science, right? So this is a female scientist. Add to that the fact that she is a Black female scientist, and that is even more of an enigma based on the stereotypical responses and things that we consider about those groups of people, right? If you make something like this your screensaver, or you have a calendar of images of people doing things that are uncharacteristic, that can help you create a positive association by changing the stereotypical view in your mind. Stereotype replacement is when you replace a stereotypical response with a non-stereotypical one. So as an example, if you're talking to one of your partners and your partner says, I have a child who's a math major in college, And you say, oh, really? What's his name? And the partner says, I'm talking about my daughter who studies math. We assume that the child who's a math major in college is probably a guy, right? That's the stereotype. The correct response, or the non-stereotypical one, would be to say, what's your child's name? That way, you don't imply gender at all. Next is decoupling. This is when we break the causal link between bias and behaviors. So some examples of this would include things like a standardized evaluation form. So instead of word of mouth about how someone's doing or just your gestalt about their performance, having pre-selected criteria that you want to judge everyone against helps take some of that bias out of the evaluation process. The same holds true for predetermined job criteria. If you're hiring for someone new in your practice, having criteria that fit with your mission, vision, and values ahead of time will remove the bias of fit. We often say that this person would fit in well here, and fit is generally meaning they're similar to me or they're similar to the other people that already work here, which just leads to more homogeneity and does not at all foster diversity. But if you have those criteria selected ahead of time, you can take some of that bias out. It's in the diverse search committees. We know that if you have diversity, not only of racial, ethnic, gender diversity, et cetera, but also diversity of thought, you tend to attract more diverse applicants. In addition, you tend to hire more diverse people. And finally, another example is blinding of applicants. We do this in our residency program where we blind certain characteristics of the application so that it doesn't bias us for or against the person. One example of that is the picture. We all know that we tend to be more attracted to those who are physically attractive, and that may bias us towards liking them or seeing their application differently. Decoupling is incredibly important. Again, there are many examples of how decoupling has been used. This is just a few of the more well-known examples. Perspective taking. This is probably one of my favorite and something I feel everyone should be able to do. It's the walk a mile in another person's shoes. It helps us lessen automatic group-based judgments and improves our psychological closeness to the group in question. So to make it a little bit more plain, let's work through a couple examples. So you want to focus on a group that you're struggling with stereotyping. Say, for example, you want to overcome a bias against Blacks or African Americans. You want to imagine what it would feel like to be considered less qualified for a position based on your skin color, or what it must be like to have a discussion of how to behave around police for your children to get home safe. Once you can imagine what that is like, you can start to empathize with that group of people, and that helps you improve the psychological closeness to the group in question. Another example, if you're working on gender bias, imagine what it must be like to lose an opportunity based on assumptions about your family responsibilities. It's the, oh, she has 3 kids, she probably has a lot of childcare needs, she probably can't take on that extra project or stay late at work because she probably has stuff she needs to do at home. When in fact, that woman may have a stay-at-home husband who handles those responsibilities, and your assumptions would be incorrect. But if you think about that and you put yourself in that woman's shoes, it helps you lessen the automatic group-based judgments. So it helps to say, okay, I probably shouldn't assume that my female partners have childcare responsibilities or going to have trouble with childcare. Another example would be to imagine what it must feel like to have your abilities questioned and have people question whether or not you can be authoritative enough or if you can be independent as a leader. Imagine what those things must feel like so you can start to empathize more with that group and break those associations. Individuation. This one's a little bit more difficult. As we talked about earlier, our brain really wants to make group-based associations and schemas to help us navigate the world around us easier. However, this technique actually asks that you consider the person and not the group. You really have to make a conscious effort to do this to avoid making quick decisions based on the stereotypes that may be very well ingrained in your mind. You want to see the individual and not the group. So when you encounter someone who's a member of a minoritized group, be it racial, ethnic, gender, sexuality, ability. Get to know the person on an individual basis and don't ascribe stereotypes to them or make them the representative of that group. This is another one of my favorites, the camera technique. You want to be like a camera when observing or interacting with others. You want to disconnect your observation, your interpretation from your observation. So simply make an observation, but don't interpret it. So take a picture, but don't interpret what the image represents. An example of this is the following. You walk into a patient room and you see two women and a young child. One woman is significantly older than the other woman. You may assume that this is the mother and grandmother, when in fact, these women are partners. You want to avoid taking that leap to assume that you know who these people are in the room based on your past knowledge and experience. You want to simply ask, who all do we have in the room? Or who all accompanied little Johnny to his visit? That way, you're simply making an observation, but you're not making an interpretation. Be like a camera. And finally, partnership building. This is borrowed from the business world, but something we in medicine can do as well, or that you can do in your own communities. You want to seek out opportunities to engage and partner with diverse individuals, both at work and at home. So say, for example, your hobby is basketball, like mine. You want to consider joining a league in a different part of town than you live in. That helps you get out of your bubble, out of your comfort zone, where the people may look and act like you, and into environments that are new. That's how you form different ideals about people. So those stereotypes that you've seen in the media disappear when you encounter those people and realize that those stereotypes really aren't true. It changes your own mindset and bias such that you're able to have successful and diverse partnerships and take away some of that bias, which creeps into not just at home, but also in the clinics and hospitals where you work. And that is it. Thank you so much for your time. I'm happy to answer any questions that you guys may have about implicit bias.
Dr. Darden, thank you so much. You may see some questions or comments that may have come in there. Folks, if you have a question or comment, please go ahead and raise a hand and we'll call on you. Dr. Benalis, do you have a question or comment right now?
Hi, Dr. Darden. Thank you so much. This amazing and very interactive presentation with so many examples are so important for us in medicine. And my question is, like, what kind of policy institutions can put in place in order to improve diversity in each institution? Are there like some guidelines for us, things that we can lead our leaders towards? That
question is huge because there's so many different aspects that you would have to tackle, right? So if we're talking, diversity in staff, then we know that we have to improve the diversity in those who are hiring staff, right? So there has to be more people at the table that look different, that have different thoughts and opinions, because that's the only way you'll attract diverse talent. If we're talking about making sure that our staff is well educated on things like implicit bias, microaggressions, so that they don't cause harm to the patients that they're encountering, then there's a huge educational piece there that then everybody has to be committed to, right? It's huge. You have to tackle it from so many different angles. There's no like cookie cutter, this is how you have to do it kind of approach.
Yeah, I can totally relate to that. Is there a another aspect of like how to combat and improve diversity is like not let the diverse person to feel alone. Having at least a partner increases the chance of retention as well. Is there like something that you personally have, helped developed at PCH in order to improve diversity?
Absolutely. So I personally feel like, at least in our residency program, our aim is to try to mirror the communities that we're serving. And so ensuring that our residents represent the community from a racial and ethnic diversity, I think, is important. And we've built a lot of things surrounding that to try to improve that, and have improved it over the last several years as I've been in this role. But also, I think one of the biggest things, because we tend to have few underrepresented minorities in our training programs across Arizona, they all tend to be the, few in each different hospital. One of the most important things to me is to make sure that they have mentors, and maybe even more importantly, sponsors that they can go to that will help walk them through this path. So I did create a mentorship program for our residents here at PCH to make sure that they had someone that they could go to who's traveled this journey before them, who knows what it's like to still have to perform well, even though you're experiencing microaggressions on a daily basis, who can ensure that you're involved in projects that will help grow your career, because I think that's the only way for them to be successful. I also do some peer and near peer mentoring for them, or orchestrate that so that they can get to know each other and really feel comfortable with each other, and they're kind of in their own little family. I think that having that support system really helps them to thrive in environments where they may be a very small minority.
Dr. Darden, John McElligott here. So we've been speaking with a lot of physicians about the idea and the data behind patients wanting to see a physician who looks like them and comes from a similar background. But that is also tied, I think, to whether a physician should share a photo of themselves, how much information they should disclose publicly. So what's your view on whether that overall is a good idea, the pros and cons? Because you talked about some of the cons of doing that. What are some of the pros, and how do they weigh out in your mind right now?
So the data supports that patient-provider communication is improved when there's racial and ethnic concordance between the patient and the provider. There's lots of good data that supports that. I think the issue that we run into, particularly in Arizona, is we don't have enough physicians to actually make that happen. So Arizona is actually pretty diverse, but our physician population is not. So that makes it challenging to actually make that happen. But I wholeheartedly believe that, at least, in the pediatric world where I am, the child who's there deserves to be able to dream and see somebody who looks like them, who maybe went through some of the things that they went through. We have residents, who are immigrants. The children who come to our hospital who are immigrants deserve to see a physician who's maybe traveled that road, who knows what they're feeling. It helps them dream and helps them believe that they can do more and be better. And I believe that they deserve that.
Thank you very much. We're just about top of the hour. I want to thank everyone for being here. I will add into the chat, which will send out to everyone, a link to receive the CME credit, the post-evaluation survey. If you're viewing this as a recording, there'll be a different link for you to follow. We'll include that in the show notes. I want to thank Dr. Alissa Darden for coming on, but turn this over to Dr. Karina Benalis for any closing remarks as well.
Thank you so much, Dr. Darden, for this first webinar for our DEI subcommittee at the Maricopa County Medical Society. It was really the basic background and important information that we need to build upon. I am so proud to have you as our first presenter, and I am looking forward to continue to work with you in the Phoenix realm, the state realm, and hopefully on the national realm to improve diversity in medicine. And thank you everybody for being here, and I hope you enjoyed, and see you in our next webinar, which is going to be every 3 months. Okay, bye bye. Have a great night.